right. Good morning, everybody. Welcome, welcome, welcome. We are so excited to have all of you here. As always, if you are watching this live, we would love for you to let us know who you are. Toss your name and where you are in the chat. We tend to get people from all over California, but also all across the nation and sometimes into Canada and other places. So let us know who you are. We are so excited to have you here. Hopefully this is not a surprise to anybody here that we've been talking about MAT at California Bridge, mostly in the emergency department setting for a really long time. And what's happened is now that we've built this army of people who are starting patients on buprenorphine in emergency departments, we are realizing that we have to help build up our outpatient care providers, our outpatient partners, to be able to make sure that our patients can access care in the regular clinics that they go to, because not everybody can access a specialty addiction clinic. So I am joined by three of my literal favorite experts in this area. I am so lucky that they volunteered their time to be here today. And I will let them introduce themselves to you very briefly. But first, I want to remind you, California Bridge Program is a part of DHCS. We are a nonprofit grant-funded organization. All of our materials are copyrighted by DHCS, and none of our speakers today have any financial disclosures. If we use brand names like, say, Suboxone instead of buprenorphine or Narcan instead of naloxone, it's not with any financial implication. It's just because we're using the terms that our patients use to keep it a little bit easier to follow along in our conversation. So, with no further ado, I am Alicia Gonzalez. I am the clinical training director here at California Bridge and a proud resident of California. And I would love for my colleagues to introduce themselves to you. Ed, I'll have you go first.
Good morning, all from California and abroad. I am with Southern California, Arrowhead Regional Medical Center. We're a county trauma burn center in Colton, California. I'm EM trained, board certified, addiction medicine, board certified, and I manage the addiction clinic in the county as well as the county jail. So it puts me in a unique situation to affect change in our recovery community, from the ED to the MAT clinic to the county jail. So it's a privilege.
Great. Rebecca.
I'm Rebecca Trotzky. I'm a family medicine doctor that's been working with California Bridge in Los Angeles area for 7 years since its founding. And I am so excited to be here to speak towards kind of all stages of continuing care and how our ER colleagues and our FM colleagues can work together.
And Monish.
Hi, everyone. My name is Monish Ullal. I am an internal medicine and addiction medicine doc in Oakland, California. I work at the Bridge Clinic here at Highland Hospital. So I do help run the Bridge Clinic and do acute care addiction consults, and have done primary care as well.
So hopefully what you guys gleaned from that, everybody attending, is that we have three outpatient experts with varying practice locations and practice environments, but all of whom work regularly in the outpatient setting. So even I plan to learn something from this, because I'm mostly an emergency-based provider. And hopefully all of you will take away that the big number one message here is that we, all of us together, are building a system in which there are no wrong doors for patients with substance use disorder to access care, whether that is the emergency department and a specialty addiction clinic or your primary care clinic. So first, let's talk about these patients in general. I know that patients who have substance use disorder can be more challenging in certain ways, more special in certain ways, and they're not your average primary care clinic that maybe is just coming for their annual A1C check for their diabetes or to adjust their blood pressure medication. So what are some things that primary care docs or outpatient providers should be taking into consideration or thinking about with this patient population in order to make their care successful? Ed, let's start with you. I know you have something to say about that.
Yeah, so I mean, over the years of my experience, I've learned, and I think everyone would agree, that patients don't care what I know, they care how I make them feel. And we have multiple touch points in the recovery community to make or break a connection. And that connection is really the foundation of moving forward. And so it's our job, no matter what the venue would be, to create an environment that fosters trust and encouragement and is non-judgmental. And as a cognitive pause, I call it the Robin Williams cognitive pause for me, because he I took a quote from him. It's been around for a long, long time, but he said something that goes like, everyone you meet is fighting battles you know nothing about. Be kind always. So if I can go into an encounter, a connection with that in mind, that often I find sets me up to be a lot more empathic, to be able to listen better, to invoke empathic gestures, and acknowledge and validate the reason that the patient's here. So I will often start by congratulating the patient. Hey, I'm glad you're here because I know it took guts to walk in here. But it takes courage to walk in here. I just had a recent patient that I took care of in the jail, that followed up in the ED through our bridge program as we have orchestrated, and now he's going to see me in the MAT clinic this Friday. And I saw him in the ER on Sunday because he got released from jail, showed up on Sunday. I saw him, and he just could not stop talking about the encounter that he and I had in the jail, and that was the main reason that he showed up. Now, I'm nothing special, but that's the reason that he's the reason why I do this.
Yeah.
So
it sounds like having even just an attitude that begets a welcoming environment and welcoming people in is a really key part of this. And how do you do that? Like, what are some practical ways that a provider can do that?
So, I spent some time as a quality director for patient experience, so I'm going to draw off of that too. And there are techniques, and I kind of just went through them very quickly. It's a LEAD kind of acronym. It's listen. We should spend more time listening than talking to these patients. Let them feel like they can trust us without judgment, and then empathically encourage the conversation. I can see how difficult that might be. It must have been difficult for you to walk in here because you didn't know what you're walking into, right? And that's very kind of disarming and helps foster that trust. But the thing that I took from this patient was he would say, no one's ever talked to me like this before. And it doesn't take much. If you remember, everyone you meet's fighting a battle you know nothing about. And if they showed up, I spent some couple of years at Betty Ford part-time over the years, and we used to have a sign there that said it takes guts to walk in here. So in terms of signage, if you want to put something up in your clinic or your ER, that's powerful. That's a powerful statement.
Yeah.
So
what I'm hearing you say is you have to practice your language, think about like radical acceptance and empathy, but also think about the audio visual clues in your clinic. Like, how have you trained your staff to talk to people when they show up late or when they walk in, or what do the signs in your clinic actually say? So that it just feels like a routine part of your life. Monish, I want to ask you, because I know that you, one of the things you talk about a lot is adopting this culture of like, just offer treatment. Like, I think a lot of people are really worried. These are going to be long, intense patient encounters. I don't have space to do a 45-minute deep dive with every patient. What advice do you have for a primary care doc who's got like, 17 minutes to get through the patient and the chart and the orders? How do they approach a patient like this?
Yeah, absolutely. I mean, having done primary care in a safety net clinic, the number 1, 2, and 3 things always on my mind was time and working through lunch and just being extremely pressed to go as quickly as possible in a super stressful way. And so what I want to encourage everyone is to really recognize that BUP starts and offering treatment for people with opioid use disorder can be one of the fastest and most high impact things you can offer someone in like a quick encounter. And the conversation can be very focused. This also, like, the context here is that the traditional like treatment modalities for addiction has been super structured and high barrier and like requiring people to do an intake that takes many hours. And there's this idea that people have to kind of confess to their drug use and like say every bad thing that they've done and really kind of unload all of their trauma and like the first time they used and all of these things. And those are all ways that stigmatize drug use and make it really a lot less likely for people to actually engage in care and accept treatment. And so sometimes the best first question is, when you like see someone and it's really obvious in their chart that they use drugs like heroin or fentanyl or whatever it is, like they had an ER visit for an overdose recently, you don't need to get them to confess. You just ask them. Sometimes the best first question, in my opinion, is, do you want some Suboxone? Can I like help you not feel sick tonight? Or like, are you interested in getting something to avoid feeling withdrawals or craving? And that can really open up the door for someone to hear from their provider that, wow, this person's like interested in helping me feel better and getting directly to what I'm interested in, which is not waking up feeling the worst flu of my life every day, as opposed to like this huge conversation about, do you want to be a sober person and in recovery? And like, it's not always necessary to get that in depth up front. Not that those conversations aren't important, but I think having a low threshold to offer treatment up front and just be like really low threshold can open up those conversations longitudinally, incrementally, which is one of the key aspects of primary care. So, you know, that's been really critical for us in terms of like being able to offer treatment really easily and really buying in and being patient-centered in a lot of ways, and avoiding like the long intakes and this like kind of myth that patients need screening, diagnosis, intake, engagement, maintenance, you know, like kind of like this very linear trajectory, which is not patients' experience often.
Yeah, what I hear you saying is this belief that all substance use treatment must be a deep 8-page screening form that like devolves into like every trigger you have in trauma and commitment to never use drugs again is really overdoing it. And that really it should be much more simple. I love to make parallels to examples like, say, diabetes. Somebody's blood sugar is high, their A1C is high. We say, hey, your blood sugar is high. We have medicine for that. Let's start you on medicine. And then over time, right, with each visit, you talk about things like eye care, foot care, dietary care. You can't do that all in one visit. Same thing with drugs. So just offer the treatment, start somebody on treatment, save their life. We know that buprenorphine is evidence-based, Suboxone being one of the most common brand names that we use. Start them on treatment. And then as you build that relationship, it's okay to start diving into some of these other topics, but take away the pressure on yourself as the doc or as the PA or the NP. Just get the treatment in the patient's hands. I love that. Rebecca, what are some of the things that you think if the average primary care doc's like, okay, I'm on board, I'm going to start this. What are some challenges or other things that are going to come up with this patient population that we need to make sure we're aware of?
Right, so we are all about getting meds to mouth, right? And thinking through every single process point that patient might encounter after our care visit, before our care visit, and trying to make that as smooth as possible. So that's about building relationships with pharmacists, whether you're in a city that has a gazillion pharmacies that are already on board and know what this medication is, or you're in some rural area that has one mom and pop shop, or more commonly now, you know, a commercial pharmacy that pretends to have lots of rules and regulations. And so calling them up when you have a moment, when you're not rushed and you're not getting that frustrated call from a pharmacist and replying with that frustrated tone of voice, building that relationship, being like, I really depend on you, my patients really depend on you, how can we make this work? Can we have some auto substitution rules? So if you don't have X brand, it's okay to substitute. If you don't have Y dose, you can put in 2 tabs of half Y to get there. Those are the things that really make it easy for you as a clinician and easy for your patients, so that when they walk in the door to the pharmacy, they know they're going to be greeted with success. And your pharmacist knows that you're on top of this. You're thinking about it, you're caring about them, you're going to be available to the pharmacist and the patient in that future moment. The second thing I make sure that patient knows is that no matter what we talk about in this conversation, that medication is always going to be there. It's going to be active for 6 months because it's a category 3 medication, it's buprenorphine. I'm always going to put naloxone refills in the pharmacy. So if they have a problem coming to me, they can always just go to the pharmacy and that medication is guaranteed to be there for them. So hopefully that builds trust, that they're not like sitting through a conversation just being like, am I going to get the med or not? Are you going to judge me or not? Am I, you know, right? They know that's reassured. And I say that like 3 times in the visit, up front, in the middle, and at the end. Like, don't forget, you have a pharmacy home now. It's XYZ Pharmacy. Here's how to reach them. They're 24/7. They're whatever, 9 to 5. They're open on Sundays. They're not. And your medication's always going to be there. And here's how to reach me if you have any problems. And that's super key, just practice advice.
What I hear you saying, because a big question we get a lot, right, from primary care docs is about diversion and concern that like the DEA is going to come after them if they're writing all this buprenorphine for patients. And what I'm hearing you say is like, that is not a thing. It's going to be fine. Like, this is known to be on the DEA side, a life-saving medication. And instead we should do the opposite. We should have at least one local pharmacy that you have a relationship with. If you're in a big city, maybe it's a few. And it's okay, by the way, it's not against the law to have a preferred pharmacy that your clinic works with, that you just know where the staff is like helpful. Their director will call you on the phone if there's a problem. Like, it's okay to have relationships with pharmacies that do a good job for your patients. And so if that, if you have that relationship, it's really good to make sure that you can troubleshoot. I do want to highlight a couple of things that are in our California Bridge Quick Start Guide when it comes to writing prescriptions. You want to make sure that you include F11.20. F11.20, that is the ICD-10 code that sort of communicates to the pharmacy this prescription is to treat opioid use disorder, because it helps them to fill out prescription correctly and bill it correctly to the insurance company. And also, there's been a lot of weirdness with insurance, like Medi-Cal, or excuse me, that's in California, but
Yep.
Medicaid type programs, selecting generic versus brand name. So please always write something like, okay to substitute brand versus generic based on coverage, because we don't care. We are not brand name loyal around here. We do not care. So make sure that you're writing those. I would save your default. We'll put those notes in the chat for you, but F11.2 is the ICD-10 code that you want, and make sure that your template says in your EHR, okay to substitute brand versus generic based on coverage. And obviously making it really obvious to your patient. I love what you just said, Rebecca. Like, call me, come back to me. I'm here for you. Don't be afraid to call our clinic from the pharmacy if there's an issue, and we can troubleshoot.
And put your direct contact line into the prescription comments for the pharmacy, not necessarily for your patient to see your mobile line, but it helps when your pharmacist is closing at like 4:30, they close in a half an hour. They just want to reach you to make sure that, the spelling is wrong, their date of birth is wrong, and they can reach you right quickly.
Perfect. Now, another thing that comes up a lot, because I think diversion and the prescriptions is a big question. Another thing that I hear from our primary care teams is like, these patients are hard for me because our clinic has really strict policies about attendance, cancellations, showing up late. And I think that we can all own that sometimes patients with drug use have a higher rate of missing appointments or canceling or being late. And I was wondering if one of you could talk about your advice to the average primary care clinic out there who's trying to see a million patients a day and stay on schedule and has worked really hard with their patients to build that kind of policy. How should they think about that with this patient population?
Yeah, it's so critical to be flexible as much as possible within the system that you're working to really actually have that on-demand access for patients, because people who use drugs, especially those with co-occurring social determinants and serious mental illness, they struggle with engaging in the traditional, what I might describe as high barrier care model of primary care, which is, oh, you want to stop using fentanyl? Come see me at 2:15 on the 18th in 3 weeks. And if you're more than 15 minutes late, you got to reschedule. And also your insurance has to be activated. If it's not, we'll get you with financials first. Those are all ways to totally exclude some of the most vulnerable patients in your community. And so kind of similar to what we were saying before, like, this doesn't have to starting someone on treatment or continuing them on treatment doesn't require a full visit. It can sometimes be like a 1 or 2 minute phone call, or even like a text message exchange if that's technically possible at your site. The idea is, this is a critically high risk population. This medication has a higher impact on someone's chances of dying from any cause than probably any other medication that we prescribe in medicine. And you want to be able to offer it at the drop of a hat and really work with patients and try and be as patient-centered as possible. And that means being okay if someone's coming in late, or if they're calling in, recognizing the urgency of addressing prescription issues if they come up from the patient side, and just being really available as much as possible to try and lower that threshold.
Yeah, and what I hear you saying is they don't have to always come in person. I think this is actually a really important thing for people to realize, because that's a little different than what I think a lot of primary care clinics do with, for example, say chronic pain. They don't want to refill prescriptions for morphine or, hydrocodone, oxycodone, unless the patient's coming in person. I'm kind of hearing you say the opposite here, which is like low threshold is better. This is a very high risk population. Their risk of death is very, very high. And this medicine is life-saving. So if they're on the phone with you, start the medicine. If they text your messaging system, start the medicine. If they come into your clinic, start the medicine. Like that's what I'm hearing. Does that sound resonate with everybody else? Yeah. Perfect. All right. So
and just to piggyback on Monish's comment, social determinants are understanding and considering the patient's social determinants are critical, because a majority of them have transportation issues. Their support is substandard, possibly lacking. And telehealth, fortunately, is, I think we can thank COVID for that, is the new normal. And there's few practice lines in medicine, I think, in healthcare that lend itself better to the recovery community. Because I think, once the relationship gets established, in my practice at least, I would say 90% is telehealth.
Yeah.
As the patients get their lives back together, jobs and relationships come back, and things get busy again. Low barrier. I tell patients from the very beginning, when we first meet or talk, is I only require two things: you stay alive, you show up. That's it. And how you do that, I'll take whatever you can give us. So.
Yeah, Rebecca, I see you put in the comments, 95% of your encounters with patients with opioid use disorder are telehealth. I think that's really important to realize. And then Monish is saying the same. Your high volume program does majority telehealth. So if there's any primary care out there who's thinking, I don't know if this is safe, I don't know if it's okay, we have our experts on this call saying they're doing the majority of their care for these patients over telehealth, which adds that flexibility really to keep them alive. And so I want to talk about actually starting the patients on the medicine. So for everybody on this attending this lecture, we're not going to do a deep dive into the evidence behind buprenorphine or why that medicine. If you need that, we have a separate 30-minute lecture. We'll pop the notes in the chat, but if you're not live in this video and you can't see the chat, you're going to just go to bridge2treatment.org, and then you can go to the tools section and find a bunch of our resources there. You can watch that video that goes over the evidence. But I want to talk a little bit more about, we have all these trainings to how to start somebody on buprenorphine in the emergency department, which we made very low barrier and really good, but ER teams are very trained in critical care. And so this was very simple for them. Are there differences when you are starting a patient in the clinic, or, they come to you in primary care and say, I want help? Is that different? How is that different?
So if I could jump in real quick. Oh, go ahead.
Go ahead.
I just haven't seen that many, in terms of the mechanics, the dosing, the starting differences between ER and outpatient care. We're starting a pretty high dose now in times of fentanyl everywhere. So we're starting 16 to 24 milligrams. And I'm also honoring my patients being the expert of when to start and if they need to repeat that dosing. So the main difference is I'm not having them come into clinic in withdrawal. I'm hoping that, in fact, they come to clinic when they feel fine and they can have a conversation. They don't even need to come into clinic at all. We can start over the phone. They pick up the medication and then they start it in their home setting. So it's important to have that flexibility of where your patient's at, and really trust them and tell them verbally, if you need to take more of this medication, that is totally fine. Here's the cues you're looking for, and I trust you. And if this is having any sort of complications or difficulty, call me and we can work through that. And there's some tools that we have to help you through any problem that you encounter. So we're looking for people to start this at home.
Yeah, and so if you're not familiar with what a self-start looks like, we do have a California Bridge tool for that. We're popping it in the chat right now. There's a protocol. It's patient-facing. You can actually print this out in multiple languages and give it to your patient, and they can start themselves on buprenorphine. So I think what I'm hearing, Rebecca, you said meds to mouth is the goal. Low threshold for starting that first prescription. Can be over the phone, can be over a video call, can be an in-person visit, doesn't matter. Give them the medication and let them start themselves, and that is safe. Ed, what were you going to say?
I was going to say, just to tag on it, because it's a perfect segue. Again, going back to the connection, William Osler said way back in the day, listen to your patient. They're giving you the diagnosis. So, if you talk to your patient, you would be surprised how many of your patients have already tried bup, Suboxone on the street. It's out there. It keeps people alive. And I'm a big fan of it. So you will learn tons. I credit a lot of my education to what I learned from patients. And they'll tell you whether they put themselves accidentally in precipitated withdrawal because they didn't know. And if that's the case, trust me, you've got a patient that you can prescribe them over the phone Suboxone or buprenorphine, and know that they're going to be mindful of avoiding that. because we're all kind of afraid of that, because that's a precipitated withdrawal, right? So just listen to your patient, ask them the questions. They've probably been on Suboxone before, and they might know a little bit more about it than you do in the beginning.
At least from a practical side of things.
Yeah,
right?
exactly.
Right.
Yeah.
Yeah. Yeah. And I mean, I want to echo what was kind of said earlier. Like I was referencing that we've done a lot of work in the emergency department. I know, Ed, you're a really big proponent of this as an ER doc in your origination in medicine, but don't forget that you also have the emergency department there for you. So if you do have a patient who somehow is not familiar with using buprenorphine or doesn't want to start on their own or is already in withdrawal, it's not a failure of care to send this patient to the emergency department. We know that patients who are using opioids have an extremely, extremely high risk of death. And I know there are some comments in the chat about other, co-substance use with methamphetamines or alcohol, et cetera. But here's the thing, like opioids are killing people, killing a ton of people. And so sometimes we have to address that one first. And that is a fatal disease. So if somebody needs help right now and your clinic can't accommodate, it's okay to say, go to the local emergency department, keep my number, let's set up an appointment for you to come and see me in 2 or 3 days, right? So that they can get you started, but I'll catch you after you start that care. It's okay to use the ED. And so it's really important for you to probably know where your closest emergency department to your clinic is, where they have a bridge program, where they do understand the basics of MAT. I'd like to say it's every ER in the country. It's not yet. It's most of them in California, but it's a good idea to just get a hold of the medical director of your local emergency department and make sure that they're comfortable and that they have your information and that they know how, to connect with you. And then a big shout out to any of our navigators who are on this call. So if you have a community health worker, a substance use navigator, a patient navigator in your local emergency department or in your clinic, either way, we want to make sure that that person knows how to communicate between the two entities without waiting on hold for an hour, without using, the same phone number as the patients. We want the real phone number so that person can help, connect patients to care. So, okay, we have the patient started on buprenorphine. We've lowered the threshold to getting them to either self-start or they start in the emergency department. They're coming to follow you. I think one thing primary care docs are not super comfortable with is how do I titrate or maintain this dose? So let's just say the patient got seen in the emergency department. They, maybe it took like 32 milligrams for that of buprenorphine, in that day to stop feeling like they were in withdrawal and feel better. And they go home on like 8 milligrams once or twice a day prescription. It was supposed to last 2 weeks. It did not. It's 5 days later. They're already almost out of it. And here you are, the primary care doc who wants to write them a longer term prescription. Monish, can you walk us through like what does that look like? How do you decide what prescription to give and how to adjust it?
Absolutely. Yeah. So, the old school, now defunct X-waiver training would have you start like 2 milligrams, then 4 milligrams, observe them in the office for multiple hours. All of that is not practiced anymore. It's much more simple than it used to be. And it's basically, you start someone on whether it's 8 milligrams, 16 milligrams, and the normal therapeutic range, like the evidence we have suggests that the minimum kind of effective dose in terms of reducing cravings and risk of return to non-prescribed opioids is at least 16 milligrams a day for most folks. And then in the era of fentanyl with really high tolerance out there, it's very normal for people to be on 24 and 32 milligrams sublingually per day. And so this is not like rocket science. The range of medications, the standard dose is 8 milligrams. So you take 2 of those a day, 16 milligrams, up to 4 of those a day, 32 milligrams. What I love about substance use disorder treatment is it's extremely patient-centered, where if a patient is reporting to you that like cravings on 16 milligrams, I have zero qualms about being like, great, let's increase it to 24 and see how that feels. Or if they're saying that they're on 32 milligrams and they're feeling extra constipation, or they're just like feeling like they don't need it and they want to go down. A lot of folks do independently kind of try and reduce their dose. That's great too, as long as it's still at an effective dose for them and they're not having cravings. And so you can be really kind of patient-centered, use shared decision-making. A range from 16 to 32 is really normal. I wouldn't recommend like really complex titrating, especially up front. The self-start guide from CA Bridge is great for this. It's just like take 2 to 3 a day, take 4 if you need to. And it's like really, really simplified from what it used to be.
Yeah.
And yeah.
Yeah. If I can chime in here. Yeah. Monish is exactly right. The early days of Suboxone and buprenorphine were based on psychiatric, it's from psychiatry. So they did that micro kind of dosing induction. But 16 milligrams is kind of the sweet spot for most people. The vast majority of the brain is going to be protected and covered. Their cravings are going to be mitigated. Our Canadian colleagues, apparently, they start at 24. And there's no really wrong dose, but I do want to put a plug in for shared decision making, because it is, we got to remember the cornerstone of patient autonomy. And there are patients out there that have a trajectory that they might want to start at a certain dose and then taper up. We have that discussion, whether that's wise, et cetera, et cetera. But just bringing the patient into the decision process, not only deepens that connection, but it also the trust and the outcomes as well are improved.
And I think also realizing a couple of practical things, which is, yes, it is okay to go in higher doses. Yes, it is okay for the patient to self-titrate higher if they need to. Like, so if you talk about it with them, they seem to think that maybe say 24 milligrams will work, but they end up taking 32 milligrams a day because they're still having cravings or symptoms, and they run out early and they call you. That doesn't mean that they're out selling it on the corner. Like, we can have an honest conversation with the patient about how maybe their dosing wasn't enough. And I do just want to say, I know there are a lot of primary care docs who are worried about things like writing long prescriptions for buprenorphine, and like what happens if they get diverted. I will let you know that there's actually, like, this has been studied, and they have seen that buprenorphine does not get diverted quite the same way as other opioid medications. And we see a lot of patients still on chronic, hydrocodone, oxycodone for pain. This is not nearly as dangerous. I will remind you that we have a full separate lecture about the safety of bupe and the pathophys and the pharmacokinetics of bupe. So we're not going to dive into that there, but it does have a ceiling on respiratory depression. It doesn't cause overdose by itself. It's a very safe medication. And so there is also a piece of us, that radical acceptance part, that like, if some of the bupe gets diverted into the community, what we know is that the vast majority of buprenorphine sought in the community, like illicitly, is actually being sought out for patients to be out of withdrawal. It is not really a medicine people like to use to get high, because they can buy fentanyl for a lot cheaper and actually feel high. I will separate that I know we had a lot of questions about the criminal justice system. That's its own microcosm of something, and I don't want to use that as the norm for the community. Monish, I can see that you have something do you have anything you want to add to that?
No, just to emphasize, the therapeutic range is extremely large for this remarkably safe medicine, and which is why we have very little anxiety about increasing doses, and just to try and release that anxiety that we have about controlled medicines and trying to minimize distribution of that, and agreeing that the vast majority of so-called diverted buprenorphine in the community is used for its intended therapeutic purpose, which is to avoid using other opioids.
Perfect. Yeah.
Yeah.
And there's a great conversation happening in the chat. What I'm just going to do is pull out a couple of the highlights, which is, remember, like you just said, high doses are okay. It is safe. And then something that's happening in the chat also is that we don't want to necessarily give patients who are just getting used to their buprenorphine a 30-day prescription, not because we don't trust them, but because it might not be the right one. You don't necessarily want to tell this patient, bye, I'll see you in 6 months, right? Like, this is somebody where you give them enough buprenorphine, but we want to see them sooner to make sure they're doing okay, that they don't need a refill, that they aren't taking extra and running out and now kind of having this period of time where they don't have your support. So just thinking about that is a really important component. And
Alicia, real quick, chronic pain, it's a big comorbidity that's quite common actually in primary care. I'm sure our primary care colleagues see a lot of those patients, and those are the patients that are likely going to need the 32 milligrams a day. And they will tell you that, this Suboxone really, it does help. It's not indicated. I can't write for it for pain, but get used to having a low threshold for using higher doses for those patients that have those chronic pain conditions.
Yeah. And so let's say we have a patient that we started them on buprenorphine either in the emergency department or in your primary care clinic with a self-start, whatever. You've maybe spent a month kind of helping titrate, figure out where the right dose is for them. They're probably going to land somewhere between 24 and 32 milligrams daily. That's the most common, but it's okay for some patients to need a little less. It's okay for some patients to need more. You have kind of found that dose that's the sweet spot. Now what? Talk to me about refills. What does that look like? What is a normal length of time that you can write a buprenorphine prescription? What does standard kind of look like in that environment?
If I can, so in the beginning, like you, I think you mentioned, Alicia, if we're trying to dial in the whatever the correct dose might be for that patient, the patient's not sure, then I'll give them 1 or 2 weeks just to kind of get a feel for what their threshold is going to be. And the reason I do that, because I've learned the hard way, pharmacies have the veto power. This is the choke point of this process. Pharmacies will refuse to do early refills on patients, except the exception is, in my experience, that one pharmacy that I have that special relationship with, that knows me, that I send the majority of our patients to, will they're more than willing to do a 1 week early refill or so, because of that relationship. So that connection is often important as well. As I mentioned in the beginning, these touch points are everywhere. It's just not with me. So yeah, and then once it's dialed in, I'm giving them 30 days with a refill, so they're never hopefully without.
Yeah, Rebecca, and you're like one of the highest number of buprenorphine prescriptions in Los Angeles County. I'm curious how you feel about the refill question.
Yeah, I am a huge believer in refills. It makes my life easier. It makes my patients' health better, and it reduces some annoyance of my pharmacist towards getting mismatched prescriptions. So I have changed my practice model from initially a couple of years ago of being like, I wanted to micromanage those doses, and I wanted to micromanage the prescription refill frequency and periodicity, to now really giving that into my patient's hands by saying, dispense 90 tabs, which is, a 24 milligram daily supply, and a whole month of those medications with refills to last the 6 months, which is the maximum that we're able to do with this category 3. And I found that some people, leave care without treatment visit being completed. They have that prescription in hand, and little do I know, they're actually filling every month with telling me I'm the worst person ever, as they left that encounter. And I'm like, okay, I hope to see you soon. And then they come back a month later and they're like, thank you so much for, giving me this medication that my brain, they don't say it, but they act it, right? My brain has calmed down. Like, I'm now back with my family members. I have been attending school, and they're thanking me for, giving them that, that ability to make that choice. So I really encourage us to live in a world where our patients might be angry with us and frustrated with us and say no today, but tomorrow might be the yes day. Tomorrow might be the day that they pick up their medication and start it. And we want to give that opportunity to them as much as possible.
Yeah, I think it's, it's amazing, this idea that we want to make it easier for our patients to access care and get medication from us, so that they're not seeking treatment, whether that's an illicit drug like fentanyl or buprenorphine, from anybody else. Like, I don't want them having to feel like they got to go to the corner to get the medicine to feel better. They should be getting that from us, so that it's safe. And I want everybody on this attending this lecture to hear, we've now had all of our experts say, oh, I write refills, no problem. I'm not worried about it. It is safe. So don't let fear be the reason that you're not doing that. But speaking of things that people think that they have to do, I want to talk about drug testing. So I know that there's a myth out there, and I will give one caveat, that when I talk about laws here, we're going to focus a little bit on California. And so there's no federal law that requires drug testing, but I do think it's important that you should know the laws in your local state. These things do vary. But what is the actual role of urine toxicology screening in the maintenance program of a patient who's coming to your clinic? So is it the A1C of opioid use? Do I need to check it every time they come to see me? Like, what is the purpose? Is there a law? Somebody walk me through that.
Yeah. So I have diligently tried to find what the DEA's expectations are, because cures in California, we have a drug monitor. Every state has a drug monitoring system. In California, it's called cures. I work in the criminal justice correctional facility, and no one can give me an answer. So having said that, some patients, they want that affirmation that, hey, good job, your test came back looking awesome. Some patients need it because they're in a process or a system where they need to show validation. for example, child custody cases, things like that. So they are interested in that. And I always tell patients, listen, if I test you, it's never punitive. Never punitive. It's going to be because I want to be able to tell you or give you some kind of guidance or advice and say, great job. Keep up the good work.
Yeah. Monish, you're working in more of a specialty clinic, a high volume specialty clinic. Do you guys use toxicology screening?
No, so definitely want to normalize not checking urine drug screening. There's no clinical diagnostic value to a urine drug test. If you're treating someone with a substance use disorder, it has no correlation with how well or how poorly they're doing. All of that is really speaking to the patient, thinking about the William Osler quote from Ed earlier. And so, that was just another historical barrier that existed to offering treatment. It's like the 3-hour intake. It's just a hoop to force someone to jump through, and kind of stigmatized, like a stigmatized hoop that they have to jump through to kind of demonstrate that they're using or not. And it's really just about talking to someone and offering treatment and not worrying about whether they're still using based on the urine drug screen. It's about the conversation. When we do use urine drug screens, it's as a conversation starter. Like, hey, I noticed you're also using meth. Like, let's talk about it. Like, where are you at with that? And opening up that conversation. If you've gotten someone on treatment, those kind of conversations are much more feasible versus using it as a tool to catch someone or, God forbid, discontinue treatment based on what you're finding on that. Certainly, we want to avoid using urine drug screenings to ever withdraw treatment, right? That's like the opposite of what we want to do. And it's totally what the old stigmatized, very traditional programs still do in the US. It's like if someone's A1C is higher, you don't reduce their anti-glycemic therapies, right? You intensify their treatment. And so that's what we want to do.
Yeah. We don't fire people with high A1Cs and say, I'm taking your insulin away. So that makes sense, right? That's like, we have to think about this as a chronic disease and approach it that way. Rebecca, I thought you were going to say something.
Yeah, sorry. I wanted to really particularly call out the legal and forensic harm of toxicologies on reproductive age people or people who are actively pregnant and parenting. They're often used as a forum to create family separations, to unintentionally or intentionally involve DCFS, which is our child welfare agencies, into removing kids from care. So when my team uses urine toxicologies is when we have clinical uncertainty for which the patient interview and exam has not given us an answer, and we've discussed it with the patient. And particularly for people who have any forensic harm, which is almost everybody in my setting, I want explicit consent. So I explain it to them why we're using it, why it could be potentially harmful, let them make the decision. We also have urine toxicologies that are commercially available products that we get and that are not in our medical record that we use to then help people in the community make community decisions, and also run our contingency management program, which is a way that we help people kind of stick to their goals. So just like we're saying, we want urine toxicologies to increase access to care rather than reduce access to care. So just be mindful of how all of our care in particular impacts marginalized communities, people of color, poor folk, and people with kids.
Perfect. Okay, another question. When do we taper people off of buprenorphine? I feel like one reason primary care teams are concerned about it is they're like, is this a forever thing? When do I stop it? How do I taper off? I know this answer, but I'd love to hear one of you. What's the short answer on that one?
Well, I'm going to go back to the shared decision making comment I made. I have to partner with the patient, and we started the Bridge program 4 years ago, Alicia, 4 or 5 years ago, and there's a fair number of patients that are still on Suboxone. I tell patients again, you stay alive, you show up, you're never going to disappoint me, no matter, you just meet those 2 requirements, and I'm good to go. But you're driving this bus, so to speak. You're going to tell me what your thoughts are, and we're going to talk about it. I'll give you my professional opinion, my experience, and put it in option, choices, and then you make your informed choice, and I will, and it's my job to support that.
Yeah.
And unless I think it's actually very harmful,
Yeah.
And
Is it standard? I don't know, Rebecca and Monish, is it standard for people to come off of buprenorphine?
So I would say it's one of these amazing medications that helps people feel well almost immediately. So my experience is that my patients are like asking me to come off of it before my science-based brain is saying that they are ready.
Yeah.
And there's other medications like this as well, such as treating psychosis, right? When we have antipsychotics really working well, our patients are like, whew, my episode is gone now, I can come off this medication. And that has a lot to do with stigmatizing, you know, certain kinds of healthcare, certain kinds of medical issues. And with opioid use disorder, the language that I'm using in the beginning part of starting treatment is different than the language I'm using later on. So I want you to start this treatment, let's see how it goes, let's check back and see how you're feeling. And at that visit, when they're telling me, I feel clear-headed, everything's going well, can I stop this treatment? At that point is when I'm like, let's see how this goes, you know, when we meet your functional goals, whatever they may be. So are you back in school, job, work, relationships, parenting, doing all the adult things that you used to be doing before this happened? Great, let's keep that going pretty strong. And then if they're interested in going down on treatment or stopping it, and this is always a patient-led decision, and I'm always communicating, when we go down off this medication, your risk of returning to use increases, period, no matter what. That's the science. I communicate that clearly and kindly to my patients. I still let them lead the call. If they want to go down or off, I'm going down very slowly and looking for those benchmarks to stay consistent. So, and it's definitely not in, again, I'm in the safety net system, so I see people in moments of great despair with, you know, severe exacerbations of substance use disorder. I'm looking for those lights to be functional, and I'm looking for a high degree of functionality and sustainability before we're like leading that dose down. And if they're very interested in dose down, then I'm going down by like 2 milligrams a day, checking in with them frequently and encouraging them at every point that it's okay to go back. It's not meaning that you're a failure. It doesn't mean you're a bad person if you have to go back to this dose. It's what your brain needs at this moment to meet your goals.
But I think I want to clarify a little bit more boldly here. The shorter answer to this question is you don't stop buprenorphine, right? Like that's not actually the goal. I think both Ed and Rebecca, I want to just like hone in. You both said, if the patient really wants to, like if you've got a patient who says, I don't want to be on this medicine anymore, I want to talk about tapering off, that's the reason you would talk about it. But as a routine matter of science, we don't just like suddenly say, we're going to take you off buprenorphine.
Oh,
That's
no.
not
Yeah,
it's
correct.
a chronic
Absolutely.
medicine. You're supposed to stay on it. Is that correct?
Yes.
Yep. Long-term survivability sustains every day you're on meds and mouth. So people stay alive when they're on buprenorphine. Buprenorphine saves lives, period. Every time people stop taking buprenorphine, their risk of death increases. So this is a situation where every single skill I'm using in a patient judo conversation to get them to continue their treatment. I'm never proposing to like, let's take you off this treatment now.
Yeah.
I'm always saying, how do I help foster a situation for which you will choose to continue to put medication in mouth? And if they do stop, letting them know it's always okay to come back. It's always okay to go back to the pharmacy, pick up the refill, or come back and restart. And so a lot of times people are like, you know, things are going so well, and then I self-tapered, and I didn't tell you, I'm so sorry, I'm ashamed, but things really are in crisis now. And then I'm like, let's just start back up again. And it's a safe place for them to come back and tell me, you know, that moment of shame for them, I'm like, how great is it for you that you recognize this in a much shorter time frame? Like it took you a week to get back into my office once you relapsed to use of opioids. And that's wonderful. I'm so glad we can continue this treatment. It looks like it's going really well for you. So encouraging at every single opportunity.
Yeah. So keeping people on it is the goal. This is not, you know, I think I want to keep comparing it to other chronic medical issues. Like we don't tell people with high blood pressure suddenly, you know, you're going to come off your lisinopril now. It's been a year. We don't tell people with diabetes, suddenly you don't need your insulin. We keep you on bupe. But if a patient is the one approaching it, we can include them. We only have 1 moment left. So I want to ask Monish one thing, retention. We talked about patients showing up late, not coming to their clinic. And that's one of the reasons that primary care docs are like, I don't want to do this. Like they're not even showing up. What the heck? Like, what should people expect? I mean, this is your bread and butter. It's like all you do all day is this patient population. What should they expect?
Yeah, so one of the things to recognize about people with who use drugs is that the care trajectories for those folks is not linear. It's uncommonly linear. So the very traditional chronic care model of screening, diagnosis, engagement, like stabilization, maintenance, recovery, or remission, that is sometimes a doctor fantasy that doesn't apply to many of the folks that we meet. Often what you're seeing is people are engaging in care and disengaging in care and cycling between engagement and disengagement. This is seen in the really like every time it's studied, retention in low threshold addiction medicine clinics is about 30 to 40% across the country. And that's pretty much the norm. So I want to normalize that. It's normal for people to fall out of care and come back. The key is what you do when people come back and how easy you make it to come back and how the culture is about dropping out and coming back. And the answer is, oh my gosh, it's so great you're here. I'm so glad to see you. Let's like get you back on treatment. It's not like, where did you go, right? It's and so structuring your clinic and your approach to care to recognize that it's uncommon for someone to literally it's less common for someone to just kind of enter into treatment and stay in treatment forever is really important. And it's also why we emphasize so much the value of that single opportunity. Every time you see someone, that's the moment to offer treatment and get them started on life-saving medication. And the whole idea of no wrong door and low threshold is recognizing that you may never see that person again, or you might lose them after 2 weeks. And so you want to be able to take every chance.
That was so beautiful. Yeah. And we're already a couple of minutes over. So I want to just offer a couple closing thoughts for everyone attending. If you want to see any of the protocols we talked about again, and you need to access those, please head to the California Bridge Program website, cabridge.org will take you there, or you can go bridge2treatment.org. Either way, all of our materials live there. I also want to point out 3 resources available to you. If you're here on this call live, it's in the chat. But number 1, obviously, bridge2treatment.org, our website. Feel free to go there. Number 2, if you are in the state of California, poison control. Poison control actually has the ability to help you walk through starting a patient on MAT or answering basic questions. So if you're in California, call your local poison control center. That's always an offer or there for you as an option. But anybody nationwide, if you have a more complex question about a patient, you know they're coming to your clinic, you've been having trouble titrating their buprenorphine, maybe they have, co-occurring methamphetamine use disorder. You're not sure if it's safe to give with benzodiazepines. It is. But if you're not sure and you have other questions, you can call the UCSF, so University of California, San Francisco, warm line, meaning Monday through Friday, 7 days a week. You can leave a voicemail 24 hours a day, but Monday through Friday, 6 a.m. to 5 p.m. Pacific time, they will call you back and talk through your case with you. So if you know you've got a patient coming up, say Wednesday, maybe Monday, you call and talk it through with somebody. That phone number is 855-300-3595. 855-300-3595, and you can call and leave a voicemail there anytime. It is free. I'm going to take one moment to recap a couple of high concepts that we're hoping you're going to walk away with. Number 1, it is great. We would love everyone to be in a perfect specialty addiction clinic, but it's not going to work out that way in real life. So it is great that we have primary care communities looking to improve the way that they care for patients who have substance use disorder. I wish we had a magic treatment for every kind of drug addiction issue, but we don't. But we can do a lot of really good work with patients who use opioids, even if it's one of multiple substances. So please think about being more aggressive with treating opioid use disorder in your clinic. To do that, think about language, be radical acceptance. You don't have to do a big intake form and screening and urine toxicology screens and all this. Like our experts have told you, just offer patients, do you want to start buprenorphine? Do you want to be in treatment? Why don't you try it? Have you ever tried it before? Very straight to the point, get it done. Meds to mouth, as Rebecca says, start the patient on life-saving treatment. And if you need a deep dive on buprenorphine and how it works, you can see our quick start videos that we've been hosting here at the California Bridge Program. Next thing, once a patient started on bupe, you can maintain and titrate that dose based on how the patient is feeling. Are they still having withdrawals? Are they still having cravings? Do they need to go up? Usually you're going to end up somewhere between 16 and 32 milligrams. These days with so much fentanyl around, it's common for patients to be on 24 to 32 milligrams daily. That does not have to be a once a day dose. It can be divided anywhere up to 4 times a day. It's the 24-hour overall dose that matters, but they can take it as a once a day, divide it into twice a day, 3 times a day. That doesn't really matter that much. So you can work with the patient for what works best for them. Remember, we don't plan to taper off of buprenorphine. OUD is a chronic disease, and patients will need this medication perhaps for the rest of their life. If they really want to come off, it's important to have an honest conversation with them about how that does increase their risk of overdose, return to use, and mortality. So it's not a thing that we're looking to do. You're probably going to have so many more questions, and that's okay. We are here for you. Email us, info@bridge2treatment.org, info@bridge2treatment.org. And I want to take one moment to say a gigantic thank you to our speakers today, Drs. Ed Pilar, Rebecca Trotzky-Sirr, and Dr. Monish Ullal. Thank you all so much for being here. And thanks to everybody who attended today for everything you will do to help us save lives.